My name is Aravindhan Veerapandiyan. I also go by Dr. Panda. I'm a pediatric neurologist and a neuromuscular neurologist at Arkansas Children's Hospital. I'm an associate professor of pediatrics at the University of Arkansas for Medical Sciences. I lead the neuromuscular program here at Arkansas Children's Hospital. And we have a robust dystrophinopathy program, which is a program that we work with patients with Duchenne and Becker muscular dystrophy as well as carriers. So we have the multidisciplinary, interdisciplinary setup with multiple providers, specialists, and ancillary staff who care for these individuals with Duchenne and Becker muscular dystrophy. From a research standpoint, we have, again, a robust research program. So we have so many clinical trials looking at different therapeutic targets for Duchenne and Becker muscular dystrophy, as well as other neuromuscular disorders. DMD, as we all know, it's a progressive disorder that causes muscle damage, right? Even though sometimes the symptoms doesn't show up until they're 3 or 4 years old, the muscle damage we know starts to happen very early on because these kids creatine kinase, which is a marker of muscle damage, is elevated from the birth. I think that's in fact the primary reason for newborn screen efforts that's been going on right now. As I said, it's a progressive disorder. The muscle damage is mainly due to a lack of protein called dystrophin protein, which is helpful for your muscle membrane stability as well as for normal functioning. And that causes this muscle weakness. And what we know is as it progresses, it can also affect obviously your walking, so you can stop walking. And most of these boys also develop heart and pulmonary weakness as well. So I think there are different therapeutic targets that's being studied for Duchenne muscular dystrophy. The most obvious or most critical one being the genetic modification therapies that includes the microdystrophin as well as the exon skipping technologies. Talk about the exon skipping strategies. Obviously it's not applicable for everyone. You have to have specific genetic mutations in the DMD gene that make you eligible for exon skipping strategies. The key importance factor here is with the exon skipping therapies, you're actually making more of your own dystrophin rather than where in gene transfer therapies, you're actually providing a microdystrophin from outside. I think before getting into the data, definitely just briefly about the EXPLORE44. It was a phase 1/2 trial looking at the safety and tolerability of multiple doses of the medicine, which is the exon 44 skipping therapy in individuals with Duchenne muscular dystrophy. It uses a technology where the actual PMO, the drug, is conjugated to a humanized anti-transferrin antibody. So that makes it so you have one monoclonal antibody and you can link 4 PMOs. So there's more PMOs that could be linked, and that makes the dosing less frequent compared to some of the already existing exon skipping therapies. We studied at the 2 different doses, 5 milligram per kilogram every 6 weeks versus 10 milligram per kilogram every 8 weeks. I think, coming to the data per se, from a safety standpoint, I think most of the treatment-related adverse events were mild or moderate, and the most common occurring in more than 3 participants in the treatment arm include procedural pain and headache. There was, I think, 1 participant who was discontinued due to a serious adverse effect of anaphylaxis, and 1 discontinued due to moderate infusion-related reaction. But otherwise, overall, the treatment-related adverse effects were mild or moderate. And I think most strikingly, the efficacy data, the effectiveness data that was presented, there was data presented on the PMO concentrations in the muscle, which is always an important thing to look at in the RNA therapies. And we have seen robust muscle concentration of the actual PMO, which is the drug, in both dose levels, and were comparable. We also looked at the dystrophin production in both dose levels, which was I think it was observed across all genotypes, and there's increase in dystrophin up to 58% of normal. The range was somewhere between 25% and 26% in comparable in both dose levels. But I think an increase in dystrophin up to 58% of normal was observed, which is again a robust dystrophin expression. I think we also looked at the CK, serum creatinine kinase, which we talked about, could be a marker of muscle damage, and usually it's high in these patients with Duchenne muscular dystrophy. And most strikingly, in these participants who were treated with Del-zota, which is again the exon 44 skipping agent that was studied in EXPLORE44, the creatine kinase level, there was a sudden, consistent, significant reduction in the creatine kinase level, more than 80% compared to baseline. And if you look at the CK level after the treatment, it was actually close to the upper limit of normal, which again, this doesn't happen in these individuals with Duchenne muscular dystrophy. Their levels are always higher. And I think this consistent CK level being lower was actually seen months after the treatment, even in the open label study. This is the first inpatient experience using this technology to deliver PMOs to the muscle. And this drug Del-zota, which is an exon 44 skipping drug, showed significant results in the biomarker data that includes increasing exon skipping by up to 67%, increased dystrophin production by an average of 25% and up to 58% of normal levels, and reducing CK by more than 80% to near normal levels. And these are striking biomarker results, especially the serum creatinine kinase levels going down to close to upper limit of normal and staying there is important to note. Another take-home point would be the safety of the drug, which is mild to moderate. Most of the adverse events were mild to moderate and tolerable. I think based on what the data that we have, we looked at two dose levels, like I said before, 5 milligram per kilogram every 6 weeks and 10 milligram per kilogram every 8 weeks. And the data for both dose level regimens were comparable. So I think the plan is to advance the 5 milligram per kilogram Q6-week dosing as a pivotal dose regimen, and we're moving into the pivotal trial possibly later part of this year. I think there's a lot of things that I could speak to that effect. One, of course, for the physicians who are not aware of this disease, to be aware of the initial symptoms and how critical the early diagnosis is for the treatment part, as well as how that can transform the disease trajectory. And I think another important point is there's a lot of therapeutics in the pipeline, like Del-zota, that can target, your genetic background, as well as some of the muscle targeted therapies and other downstream therapies in the pipeline. And I think it is critical for these physicians outside of the neuromuscular world who is to be aware of, so that if they see a patient, so they can refer them appropriately for the management. Del-zota is targeting a specific subset of individuals with Duchenne muscular dystrophy who have deletions that are amenable to exon 44 skipping. Typically, these boys have a phenotype or a clinical presentation that is slightly milder than your quote-unquote typical Duchenne phenotype. So if you look at that, and there's a pretty good chance that these boys are being excluded from other clinical trials and other treatment trials just because of their phenotype being slightly milder. So I think addressing that critical need is extremely important. And overall, though we have a lot of therapeutics in the pipeline, there is still an unmet need, as a lot of the treatments are not cure. They're mainly to slow down the progression of the disease. So researching these critical novel therapeutic targets, and also in the future looking at add-on or combination therapies is going to be extremely important for these individuals to transform their disease trajectory.